Good morning. My name is Diana Leia M. Mendoza, RNT, MLSA CPI. I will be the one discussing the questions and answers for blood banking. First question. Biochemical changes occur during the shelf life of stored blood. Which of the following is a result of this storage lesion? The choices are the following: A. Increase in pH, B. Increase in plasma potassium, C. Increase in plasma sodium, or letter D. Decrease in plasma hemoglobin. The answer is letter B. Increase in plasma potassium. So let us remember, as the blood cells continue to metabolize in vitro, we observe the loss of viability as well as cellular functions. These functions include the red cell's ability to deliver oxygen and increase the generation of potentially harmful waste products. So what we can observe in times of storage lesion? So the glucose, hence the ATP, as well as sodium, pH, 2,3-biphosphoglycerate, and also the percentage of viable cells are observed to be decreased. Whereas hemoglobin, ammonia, potassium, and lactic acid are observed to increase. With this observation, we can also understand the oxygen dissociation curve. So what we can observe during storage lesion is a shift to the left, meaning there will be an increase in hemoglobin and oxygen affinity, so less oxygen will be delivered to the tissue. So for this question, the answer is letter B. There will be an increase in plasma potassium. For question number 2, a woman wants to donate blood. Her physical examination reveals the following. Her weight is 110 pounds. Her pulse is 73 beats per minute. Her blood pressure is 125/75 millimeters mercury and hematocrit of 35%. Which of the following exclusions applies to the prospective donor? The choices are the following. Letter A, pulse too high. B, weight too low. C, hematocrit too low. Or letter D, blood pressure too low. So, the answer for number 2 is letter C. The prospective donor's hematocrit is said to be low. So remember that we have criteria for allogeneic donation. So for age, it should be at least 16 years old or greater. For hemoglobin, it should be equal or greater than 12.5 gram per deciliters for female. Or for males, we have equal or greater than 13 gram per deciliter hemoglobin. For hematocrit, for females, we have, or it should be equal to or greater than 38%. For males, it should be equal or greater than 39%. The donor's body temperature must not exceed 99.5 Fahrenheit or equivalent to 37.5 Celsius or centigrade. The donor's pulse must be regular and fall between 50 to 100 beats per minute. The donor's blood pressure must be no greater than 180 millimeters mercury for systolic and no greater than 100 millimeters mercury for diastolic. So the answer for number 2 is letter C. For number 3, if a donor weighs 105 pounds, how much blood can be safely drawn from this prospective donor? So what we know that from our previous item, a prospective donor should have at least 110 pounds or equivalent to 50 kilograms for them to be able to donate a 450 ml of whole blood. This being approximately about 12% of the total blood volume, or the 10.5 ml per kilogram body weight. So therefore, if a donor is less than the required pounds, okay, or weight, the amount of blood to be collected shall be reduced in proportion also with the amount of anticoagulant. So what we can do is to compute for the reduced volume factor for us to compute for the amount of blood to be collected and the amount of anticoagulant to be needed. So in this question, the given is 105 pounds. So we can use this to identify the reduced volume factor. So the question is using the pound unit. So we should also use the pound unit as our denominator. So for this is equal to weight of the patient all over the required weight for prospective donors, which is 110 pounds. So to translate, our given is 105 pounds and 110 pounds divided by 110 pounds. So this is equivalent to 105 divided by 110 is 0.955. So we can now use this value to compute for the amount of blood to be collected and the amount of anticoagulant to be needed. So to answer this question, amount of blood to be collected is the reduced volume factor multiplied by 450 ml. So for this, we have 0.955 multiplied by 450 ml. 0.955 times 450 ml is equivalent to 429.75 ml. So in this question, this is about 430 ml. So the answer for this question is letter C. If there are follow-up questions asking if how much anticoagulant is to be needed or how much anticoagulant to be removed, what we can do is this. First is compute for the amount of anticoagulant needed. So that is RVF, or the reduced volume factor, multiplied by, in a 450 ml, we use a 63 ml of anticoagulant. So for this, if we have an RVF of 0.955, we just multiply it by 63 ml. So 0.955 times 63 ml is 60.165 ml. So this would be the amount of anticoagulant needed. Therefore, the amount of anticoagulant to be removed is computed as 63 minus the amount of the anticoagulant needed, which is 60.165. So that is about 2.835 ml. So for number 3, the amount of blood to be collected in a 105-pound donor should be 430 ml. And the amount of anticoagulant needed in this case is 60.165 ml. Therefore, the amount of anticoagulant to be removed in a 63 ml worth of anticoagulant is 2.835 ml. So next question, number 4. For aspirin or aspirin-containing medication, platelet pheresis donor should be deferred for blank hours after ingestion of aspirin. The choices are 12 hours, 36 hours, 48 hours, and 72 hours. So according to the AABB, or formerly known as the American Association of Blood Banks, aspirin or aspirin-containing medication as well as ibuprofen will not affect a whole blood donation. There is no restriction in this case for whole blood donation. But apheresis of platelets product or platelet products can be affected if these medications are taken for or within 48 hours prior the donation procedure. So the answer for this question is 48 hours. So bakit nga ba? So 2 days if we have aspirin intake. Aspirin is mainly used as an anti-inflammatory drug, also used to reduce fever, also as a pain reliever, and a blood thinner. So we focus on this part since it affects, or aspirin as a blood thinner affects mainly our platelets. So bakit nga ba? So aspirin is known as a deactivating agent of your cyclooxygenase. Your cyclooxygenase is needed in the platelet adhesion cascade that will act upon your arachidonic acid, which will later be converted to thromboxane A2. Your thromboxane A2, this is needed to stimulate a cascade of events resulting to platelet secretion and platelet aggregation. So, kapag may aspirin, the platelet function is deferred or affected. For number 5, persons who have received hepatitis B immunoglobulin must wait blank to donate blood to be sure they were not infected, since hepatitis B can be transmitted through transfusion to a patient. So, your hepatitis B immunoglobulin, this is an injected material used to prevent infection following exposure to hepatitis B. So, although HBIG does not always guarantee prevention from the Hep B infection, so persons who have received HBIG should wait for about 12 months for them to be able to donate blood. This is to ensure that the donated blood will not cause hepatitis B infection to the patient after transfusion. So for number 5, the answer is letter C, 12 months. So we have other types of medications with the designated deferrals and important notes. So for growth hormone, which is from human pituitary gland, which is prescribed to children with impaired growth, there is a risk for Creutzfeldt-Jakob disease, given the consideration that this is obtained from human pituitary gland from the brain. So the deferral for this medication is permanent. Proscar, Propecia, Accutane. This Accutane, Soriatane, Avodart, Tegison, these are medication that can cause birth defects. So, depending on what type of medication, for Proscar, Propecia, Accutane, following last dose, it should be deferred, or the donor should be deferred for 1 month. Soriatane, following last dose, the donor should be deferred 3 years. For Avodart, the donor must be deferred for 6 months after the last dose. And Tegison, okay, that would be a permanent deferral for the donor. Insulin from cows, such as your bovine or your beef insulins, there is a high risk for mad cow disease. So the deferral is indefinite. Feldin, which is a non-steroidal anti-inflammatory drug, has an effect to platelet function. So, for this, if you want to donate for platelet or platelet apheresis, donors who had Feldin medication would be deferred for 2 days. And also, considering that this affects mainly platelets, this medication, Feldin, will not affect whole blood donation. Okay, number 6. The last unit of autologous blood for an elective surgery should be collected no later than blank hours before surgery. For this question, let us remember that the guidelines for autologous donor suitability have been established by the AABB. But the respective facility where the patient is currently admitted should have the final say or final decision for the autologous donation. So it is generally accepted that the minimum allowable time between the last autologous donation and the schedule of surgery is about 72 hours or 3 days. Although some facilities would allow further or more than the 72 hours suggested time of the AABB. So why not 24 hours? Why not less than 72 hours? Why should it be 72 hours or 3 days? So this time is very critical for the patient to allow its bone marrow to replace the blood that was lost during the donation. So therefore, it is suggested that before the surgery, autologous donation should be scheduled 3 days prior the surgery. 3 days prior the surgery. So for this question number 6, the answer is 72. So for the general requirements for autologous pre-deposit donation, there is no actual age limit, weight, no strict weight requirement, but we have to subtract 4 ml for every excess pound below 110 pounds. A hemoglobin of about 11 gram per deciliter, and the hematocrit of 33%. Frequency of donation should not be more frequent than every 3 days. And the last donation should complete at least 3 days before scheduled surgical procedure or for 72 hours. For medical history, the donor should have no signs or symptoms of active infections. So good medical history is also a requirement. For number 7, what are the compatibility requirements for an autologous unit? Choices are letter A, ABO and RH typing, letter B, type and screening, letter C, major cross-match, or letter D, all of this option. So, for autologous blood donation or transfusion, there are certain tests to be performed prior the actual transfusion. So for the autologous blood unit, an ABO and RH typing must be performed. The same goes with the recipient. We have to remember that the antibody screening and major cross-match are not required for autologous transfusion or donation, although sometimes immediate spin has to be performed. For number 8, what should be done first if a mother types as O and the baby types as AB? So the choices are letter A, report the results with no further testing. Letter B, try to get a sample from the father. Letter C, recheck old labels, get new samples if necessary, and retest. Or letter D, retype using all new reagents. It is not routine to find an AB infant born to an O mother, as the mother carry a genotype of O, definitely a phenotype of type O, with a father of either type O, type A, type B, or AB. The possible types or genotypes of its offspring could be OO, AO, BO, leaving to phenotypes of type O, type A, and type B, respectively. So, in this case, several troubleshooting steps should include rechecking the labels, getting new samples, and retesting the samples in order to identify whether it is a clerical error or there are possible rare instances that this infant is really AB, which is born from an O mother. If the collection, labeling, and transport of the specimen is determined to be correct and no other errors was committed, we have to take into consideration other factors. In the rarest cases, an AB and a type O or type AB and type O parents producing an AB child, which cannot be explained in terms of the usual inheritance pattern. This instance could be attributed to cis-AB type or cis-AB blood type. It is possible. So what is cis-AB? It refers to the inheritance of both AB gene from one parent carried on one chromosome and an O gene inherited from the other parent. This leads to an offspring with inherited 3 ABO genes instead of the usual 2. So we term the use cis-AB to distinguish the mode of inheritance from the more usual type AB phenomenon in which the alleles are located on different chromosome. In this case, in this table, you can see that there is a type AB typing female and type O typing male. So, in crossing over, there is an equal crossing over, which is a very rare occurrence. The possibility or the rarest possibility that in offspring or a child can inherit the ABO gene from the mother and from the father. So the genotype of the offspring is ABO, which is the cis-AB. Hence, its phenotype is AB or type AB. For number 9, which of the following blood groups reacts least strongly with anti-H? The choices are letter A, group O, B, group A2B, or letter C, group A2, or D, group A1. Of the following groups that are listed, A1 or type A1 or group A1 has the least amount of H antigen and therefore it would react least strongly with anti-H. So the answer for this is letter D, A1. If you can recall the amounts of H antigen among the different types of ABO types, so we can attribute the highest amount of H on type O. This is followed by type A2, followed by type B, followed by type A2B, followed by type A1, and type A1B. So, type O has the greatest amount of H antigen, while A1B on this side has the least amount of H antigen. The Bombay phenotype individuals typing as type O on serologic testing because these individuals lack A antigen, B antigen, as well as H antigens. So these individuals make anti-A, anti-B, and anti-H, strongly reactive anti-H in its plasma. So for number 10, if the patient's red blood cells were tested against anti-H lectin and did not react, this person would be identified as choices: A, acquired B, OH phenotype, C, secretor, D, subgroup of A. The negative reaction with anti-H lectin signifies the lack of H antigen on its red blood cell, and this is seen in among individuals that are known to be OH phenotype. The listed antisera here are the most common antisera that we use in blood banking, including the anti-A1, anti-B, and anti-H. Others, we have anti-M and anti-N, and then we have other lectins that are useful in evaluating the rare phenomenon of polyagglutination. This is a problem of the red blood cells that are clumped, which is sometimes seen among patients with septicemia and necrotizing enterocolitis. For number 11, a patient's serum is incompatible with O cells. The patient's red blood cells give a negative reaction to anti-H lectin. What is the most likely cause of these results? Letter A, the patient may be a subgroup of A. B, the patient may be a Bombay individual. C, the patient may have an immunodeficiency. Or letter D, the patient may have developed alloantibodies. So from our previous items, we have discussed that Bombay phenotype individuals will give negative reaction to anti-H lectin. Also, their serum is seen to be incompatible with O cells. So for this question, number 11, the answer is letter B. The patient may be a Bombay phenotype. What do we expect with patients with subgroup A? Subgroup A would give still a positive reaction with anti-H lectin. So anti-H lectin will still react with the red blood cells of patients that may be a group of A, since they still have H antigens on their red blood cells. For those patients with immunodeficiencies, negative reactions for both forward and reverse grouping may be observed, as well as a negative reaction with O cells. So this is seen with patients with immunodeficiencies, group O newborn, or agamma-globulinemia patients, or patients with agamma-globulinemia. Even with the negative reaction for both forward and reverse typing, we can still observe reaction with anti-H lectin. For number 12, a person's saliva incubated with the following antibodies and tested with the appropriate A, O, and B indicator cells giving the following test results. For anti-A, the test result is reactive. For anti-B, inhibited. Anti-H, inhibited. The person's red cell ABO phenotype is, the following choices are A, type A, B, type AB, C, type B, or D, type O. We can recall that H antigens are precursor of A and B antigens. A, B, and H antigens may be found in the body secretions such as the saliva, urine, milk, exudates, tears, bile, amniotic fluid, and digestive fluid. The presence of these substances or H substances in the secretions is controlled by the SE gene. So SE gene is capable of expressing the ABO and the H antigens in secretions. So if you have the allele of SE, big S, small e, you are capable of expressing the type of or ABO type and the presence of H antigens in its secretions. So if you are type O, you are a group O secretor. So in your secretions, you will have H antigens. If you are group A secretor, you will have both A and H antigens in your secretions. Group B, you will have B and H antigens. And in group AB, you will have A, B, and H antigens in the secretions. So in this case, anti-A, to determine the secretor status of an individual, what we can do is to test its saliva using the principle of agglutination inhibition. So in this test, presence of agglutination or reactivity means a negative result or negative test, while no agglutination or absence of agglutination would be interpreted as a positive result. So in this panel of results, anti-A, reactive, this shows a negative result. Anti-B and anti-H, which are inhibited, this shows a positive reaction. So meaning to say, in the person's saliva or secretions, we can observe the presence of B and H antigens. So therefore, the patient is group B secretor. So for this question, number 12, it is letter B. Number 13, which typing results are most likely to occur when a patient has an acquired B antigen? So, before we can answer this, let us discuss first the acquired B phenomenon. Let us discuss first acquired B phenomenon. Acquired B phenomenon occurs when the bacterial deacetylase converts the N-acetylgalactosamine seen among type A individuals to alpha-galactosamine, which is quite similar to the D-galactose found in type B individuals. This phenomenon is associated with the conditions such as carcinoma of stomach, colon, or rectum, also intestinal obstruction, massive infection, lower gastrointestinal tract, infection, and also septicemia, which are attributed to Proteus vulgaris. In an acquired B phenomenon, these antigens are often associated with carcinoma of the colon, of the stomach, also with gram-negative infection and intestinal obstruction. So acquired B occurs in group A people when the microbial enzymes deacetylate the determinant sugar among type A individuals, which is your N-acetylgalactosamine. So it will resemble the B sugar or type B sugar, which is the D-galactose. So in a forward typing with anti-A, it will be typed as type AB with a strong reaction with anti-A, with a weak reaction with anti-B. Backward typing, it would be typed as group A individual. So in this question, the answer is letter C. A strong reaction with anti-A, a weak reaction with anti-B, and a backward typing for group A individual. For number 14, a patient has the following ABO typing result: a forward typing of anti-A 4+, anti-B 4+, anti-AB 4+, with a backward typing or reverse typing A1 cells and B cells negative. Choices are the following: A, type O, B, type A, C, AB, or letter D, not able to be determined with the information given. So what we observe here are strong reactions on forward typing anti-A, anti-B, and anti-AB. So this would suggest that the phenotype of the patient could be type AB. So in this case, with a strong reaction, we can assert that this one or this patient is a type AB individual. A positive reaction in this test with anti-AB indicates the presence of both antigens A and B. In some instances, with the presence of subgroup AX or an AXB phenotype, we can observe a positive reaction with anti-AB. But this reaction shows weak agglutination. Unlike this, it shows a strong positivity with anti-AB and anti-A and anti-B. For number 15, the following reactions were obtained: a 4+ reaction for anti-A, 3+ reaction for anti-B, 4+ reaction for anti-AB, and 2+ reaction for A1 cells and 4+ reaction for B cells. The medical technologist washed the patient's cells with saline and repeated the forward typing. A saline replacement technique was used with the reverse typing. The following results were obtained: anti-A 4+, anti-B no agglutination, anti-AB 4+, A1 cell no agglutination, and B cells 4+. So in this case, what we can observe is a rouleau formation. So to resolve rouleau formation, what we can do is saline replacement technique. So this discrepancy is caused by rouleau formation, and this can be resolved by saline replacement technique. This reaction are seen in times of elevated globulin and elevated fibrinogen. Elevated globulin, we can see this in cases of multiple myeloma, Waldenstrom macroglobulinemia, and other plasma dyscrasias. Number 16, what corrective action should be taken when rouleau causes positive test result? So, Remember that RULU is brought about by abnormal or presence of abnormal proteins in serum. Therefore, the resolution for this is accomplished by removing the offending protein. So in this case, in the choices, the answer is letter A, perform a saline replacement technique. So, the resolution for RULU formation for forward grouping, this is resolved by washing the patient cells and repeating the testing. For the reverse grouping, the saline replacement technique must be performed. First, the serum and cells are added together and then centrifuged. After centrifugation, the serum is then removed from the tube and saline added as a replacement of the serum. This mixture is then recentrifuged and re-examined. If the RULU or the agglutination was dispersed, it is attributed to RULU formation. But if it is true agglutination, it will not be affected. So, for number 16, the answer is letter A. Number 17, which of the following could be the possible cause of the given ABO discrepancy? An anti-A reaction of 4+, anti-B reaction of no agglutination, A1 cells no agglutination, B cells 4+, O cells 3+. The choices are A, acquired B phenomenon, B, A1 subgroup, C, A2 subgroup, or D, polyagglutination. So in this panel, what we can observe is a possible reaction of A1 subgroup. A1 subgroup. This is resolved in or confirmed with the use of anti-A1 lectin. Additional tests would include A2 cells or O cells or OH cells if available. So, we should remember that we have the most common subgroups of A phenotype. We have the A1 subgroup and A2 subgroup. This accounts for over 99% of individuals who are classified as group A individuals. So A1 cells or subgroup A1 have A antigen and A1 antigen. So meron siyang A antigen and A1 antigen. With this, the antibody present is anti-B. With anti-B. For A2 cells, A2 is actually or not really a unique antigen. It is thought to be simply as A antigen with no A1 antigen. So meron lang po siyang A antigen. For this, since wala siyang A1 antigen, it is known to produce anti-A1. So, bukod dun sa anti-B, we also observe presence of anti-A1. So, for this question, what we can observe is, yes, we have A antigen, anti-A antigen confirmed by the forward reaction with anti-A, and then the B reaction or B cell reaction of 4+, and of course the O cells reaction of 3+. So number 17, the answer is letter B. Number 18. For number 18, a patient has the following ABO typing result. An anti-A reaction of 4+, anti-B reaction of no agglutination, anti-AB 4+, A1 cells 2+, and B cells of 4+. Which of the following causes would be the best explanation for these results? Although there is already a clue that there is a reaction with A1 cells, so this would probably be the A2 subgroup. As discussed a while ago, A2 subgroup have A antigen but without A1 antigen. Therefore, this type of subgroup produces anti-A1 and anti-B. It reacts strongly with B cells in the reverse typing or reverse grouping, and it reacts with A1 cells but not strongly as the B cell reaction. So in this case, A2 subgroup is the answer. For number 19, a mixed-field agglutination pattern with anti-B and anti-AB typing sera is characteristic of type. For this B phenotypes, this is the characteristic of B3, phenotype B3. So we can observe a mixed-field agglutination with the reaction of anti-B and with the reaction of anti-AB. So the answer for number 19 is B3. Other reactions would include with anti-H and no reaction with anti-A. So commonly for a B phenotype, we have this usual reaction, positive for anti-B and positive for anti-AB. For phenotype B sub X, we have a weak reaction with anti-B and anti-AB. For B sub M reaction, we usually observe a no or weak reaction for both anti-B and anti-AB. And for B sub L or EL, we observe no agglutination with anti-A, anti-B, and anti-AB, but with a positive reaction with anti-H. So we have to understand also the antibodies present in their serum, all of which contains anti-A antibodies, anti-A in their plasma. Substances present in saliva. Antigens B and H are present in B phenotype with B sub 3 phenotype and the B sub M phenotype. For B sub X and B sub EL, they only have or they contain H antigen in their secretions. For number 20, based on the following reaction, what is the person's most probable genotype? So using the antisera provided, the antisera reaction shows that there is a positive reaction for anti-D, for anti-big E, and anti-small c, while negative reaction on anti-big C and anti-small e. This indicates the presence of the D antigen, the small c antigen, and the big E antigen. Using the Fisher-Race nomenclature, this is the big D, small c, big E, which is equivalent using the Wiener shorthand designation of R2. So in this case, the answer is letter B, R2, R2. For number 21, a white female's red blood cells gave the following reaction upon phenotyping. A positive reaction for D antigen, C antigen, big C antigen, small C antigen, small E antigen, and a negative reaction with the big E antigen. So which of the following is the most probable Rh genotype? So for this question, it is helpful that you are familiar with the frequencies of the genes, especially for Asians, for blacks, or for whites, or Caucasians. So the answer for this should be based on the frequencies of the genes. The gene that codes for the haplotype of the female whites. The female whites usually are dominantly or predominantly have a haplotype of D, C, E, and the big D, big C, and small e and small d, small c, and small e. So in this chart, we have this and we have this for whites. So sino dito ang magko-code sa ating antigens na D, big C, small e, and small d, c, or e? So, translating the choices, big R1, big R0, this is your D, C, E, D, C, and E. For R1 in small r, we have the big D, big C, small e, and small d, c, and e. For R1 and R2, we have the big D, big C, small e, and big D, small c, and big E. For our big RO and small r apostrophe, we have your D, C, small e, and small d, big C, and small e. Take note that I'm using bars to indicate small letters. So, that you can understand or hindi tayo masyadong malito if this is big or small letter. So, in these choices, this is presented by letter B. Letter B is actually the correct answer, which represents the majority of the female white haplotypes. So, number 22, if a patient has the Rh genotype of big R1, receiving a unit of packed red blood cells from an big R1, small r individual, what Rh antibody might be the patient develop? So what would be the antibody that this patient might later on develop? So let's translate first the given haplotypes. So big R1 is equivalent to big D, big C, small e, big D, big C, small e. And the packed red blood cell source genotype, big R1 and R, is equivalent to big D, big C, small e, and small d, small c, and small e. So if this packed red blood cell is transfused to the patient, what would be the possible antibody that this patient develop? So as you can see here, what is present antigen in the packed red blood cell which is absent in the patient's genotype? It is the small c. So the answer for this question is letter B. The patient might probably produce anti-small c antibody acting against the present small c antigen or small c antigen in the packed red blood cell. So the answer for number 22 is letter B. For number 23, in an emergency situation, Rh negative red cells are transfused into an Rh positive person of the genotype big C, big D, small e, big C, small d, small e. The first antibody most likely to develop is which of the following? Anti-small c, anti-small d, anti-small e, or anti-big E. So, the question indicates that the transfused red blood cell is Rh negative. Rh negative individual, its genotype commonly is attributed to small r. So this is equivalent to the if a person has an haplotype of small r, the antigens present is small c and small e. Of course, without the presence of the D antigen. So in this case, since the E antigen is present already in the genotype or the blood or the red blood cells of the person receiving the blood, therefore it won't produce antibody against the small e antigen. However, the absence of the small c antigen in the recipient will induce or will cause the production of antibody against this. So in this question, the answer is letter A, anti-small c. For number 24, which donor unit is selected for a recipient with anti-C? So the choices are the following. What we don't want here is, we don't want to transfuse blood units containing C antigen. So we want to identify which of the following blood units does not contain C antigen. Before that, we have to be familiar with the antigens present based from the genes or the haplotypes that is presented here. So using this table, we can identify the presence or absence of the C antigen on the following given choices. So let's identify first which of the following gene based from Fisher race contains or does not contain C antigen. So we have this, we have this, and this. So we have 4 possible genes which does not give us C antigen. So anything that will not fall to this genes or gene type, it contains or it can code the C antigen. So for letter A, possible kaya to? Let's see. So R with 1 apostrophe, we have C and E. Pwede yung isa. But the other one is D, C, E. So this codes for a C antigen. So tanggal na siya agad. Okay? Letter B. R0, R0, which codes for DCE, DCE. So again, meron siyang C antigen, so hindi siya possible answer. R2, which is D, small c, big E. And we have the small d, big C, and small e. Here, we can see C antigen. So, this is not a possible answer. The last choice would be R1 apostrophe and RY. So, let's see if this is really possible. So, this codes for DCE with the big C, and your RY codes for small d, big C, and small e. So, okay tayo since it does not contain or it will not introduce small c antigen to the recipient containing anti-C. Number 25, what is one possible genotype for a patient who develops anti-big C antibody? So in this question, we want to look for the possible genotype combination of or haplotype of the patient which does not code for the C antigen, the big C antigen. So using the table here, this gene does not code for the big C antigen. This one as well, here, and this. So we have 4 possible choices. So using these genes, we want to check if this combination can produce big C antigen. So letter A, R1 codes for big C antigen using this gene type. And small r produces small d, small c, and small e. So this won't be the possible genotype of the patient because the R1 codes for the big C antigen. Siyempre, hindi na po yung letter B. Letter C, R apostrophe and the letter R, this produce big C and small e, and small c and small e for letter R. So this gene type exclude this choice or option for number 25, and the last choices would be letter D, R, which is known as your Rh negative genotype. So we have RR, which is the DCE, DCE. The answer is letter D. Letter D.